That's it, your slides are up. Dev, you need to take yourself off mute.
Right. Hello there. Can you hear me okay?
Oh, yes, we can hear you now.
Yeah.
Thank you.
Brilliant. Great. Fantastic. Okay. Welcome, everybody. Thank you for giving up your evening to attend this talk. So we're going to talk about peripheral arterial disease and varicose veins today. So the main outcomes of this talk is essentially to talk about peripheral arterial disease, varicose veins, and the common problems that you encounter in primary care when you see these patients. It's mainly how to recognize these conditions and manage some of the common problems that you're likely to encounter. Uh, when we talk about peripheral arterial disease, it's a very common problem. As you know, about 1 in 5 people over 60 years of age have peripheral arterial disease. And a lot of these patients tend to be asymptomatic. So you identify them when they go for routine screening or testing, or when they come to your clinic and you examine their pulses and you can't feel their foot pulses. Alternatively, I think probably most commonly in the GP practice, these patients can present with symptoms suggestive of intermittent claudication. And uncommonly, but possibly they can present with critical or chronic limb-threatening ischemia. So these are the most common spectrum of presentation in patients with peripheral arterial disease. So what are we concerned about when we talk about peripheral arterial disease? There's a few things as a vascular surgeon that concerns me in these patient cohort. Firstly, the risk of having a major adverse cardiac event. So essentially, it means that the risk of having, a heart attack or a myocardial infarction or a stroke. There's also other problems associated with peripheral arterial disease, as we all know, like this picture that you see where, patients have had a major limb amputation. So they are all termed as major adverse limb events. So these are the two main complications that we want to prevent in these patient cohort with peripheral arterial disease. Let's talk about the spectrum of disease. So when we talk about asymptomatic peripheral arterial disease, these patients are usually identified either on clinical examination when they come to you and you examine their foot pulses and you can't feel their foot pulses, or they go for a routine screening test and they come up with an abnormal Doppler result, which is usually an ankle brachial pressure index. So if the patients are asymptomatic, they do not require a referral to the vascular service because they're not likely to require any further investigations or interventions. The treatment for asymptomatic peripheral arterial disease is best medical therapy. And the reason for that is to reduce the risk of major adverse cardiac events like MI or stroke, and also to reduce the risk of major limb amputation. We will discuss what best medical therapy means in a few minutes. So this is a patient cohort that you're more likely to encounter in the general practice, I think. Leg pain. Leg pain is so common. And one of the common causes of leg pain in elderly patients tend to be intermittent claudication due to peripheral arterial disease. So as you all know, typically patients with intermittent claudication, they present with walking or exercise-induced cramping pain in their calves, which is relieved by rest. And when they walk again a certain distance, they get the pain again. So that's typical of intermittent claudication pain. This pain is not there when they take their first few steps. It only comes on after walking for a certain distance, and it goes away when they rest for a bit, and it comes again when they walk. That's typical. When we look at natural history of these patients with intermittent claudication. It's actually quite a benign quite a benign disease. So this is the Edinburgh Artery Study done in the 1980s, a large population-based study that showed that 70 to 80% of patients with peripheral arterial disease are likely to remain stable. So they get pain on walking, but the symptoms are likely to remain stable. There's 10 to 20% of them can have worsening symptoms. So the claudication distance gets shorter and shorter, and it can affect the lifestyle significantly. And about 5 to 10% of these patients can progress to a more severe form of peripheral arterial disease, which is chronic limb threatening ischemia. So, as vascular surgeons, we mainly focus mainly on treating patients in the last category, is those patients who get critical limb ischemia, and also those patients who get lifestyle limiting claudication pain. So the 70 to 80% of claudicants that get referred to us do not require any treatment because they're likely to remain stable. So these are some interesting facts about patients with intermittent claudication pain. Now, I'm sure if I ask you to guess what is the main risk in these patients with intermittent claudication, because often patients want to, when you say they've got peripheral arterial disease and blocked arteries or narrowed arteries, they're worried about whether they're going to lose their leg if something is not done about it. Actually, when you look at the evidence, the risk of major limb amputation in patients with intermittent claudication, if they're untreated, as in if they don't have any surgical intervention, is actually very low. So it is 1 to 2% over 10 years. Um, and if patients are diabetic, then it's about 5% risk of losing the leg over 10-year period. That's actually less than 1% a year, which is actually very low. But what is more concerning in these patients is a risk of major adverse cardiac events, risk of dying from coronary artery event or a stroke is actually very high. It can be as high as 10 to 15% over 5 years. So that's significantly higher compared to um, the risk of losing the leg or limb problems. And most of our efforts are targeted to reduce patients' risk of major adverse cardiac events when they present with intermittent claudication pain. So this is the NICE guidelines. I'm sure you're all familiar with the NICE guidelines on intermittent claudication. Um, there's best medical therapy. So we'll talk about what best medical therapy means. So the antiplatelet of choice is clopidogrel, 75 milligrams once daily, not aspirin. So if patients are on aspirin and they have a proven diagnosis of peripheral arterial disease or intermittent claudication pain, then we would recommend changing the antiplatelet medication to clopidogrel, 75 milligrams once daily. And that's for lifelong. Now, statin therapy, I know, is controversial in the GP world. Lots of patients have side effects, but there's good evidence that high dose statins are beneficial in reducing the risk of major adverse cardiac events in these patients. The rest of the things, the vasodilator that we use, naftalin oxalate, it's a trial. It works at best in 50% of patients. And the reason we give them the drug is to increase their walking distance, and it may or may not work. It's worth a try for 3 months duration. Based on some new evidence from a randomized controlled trial a few years ago, um, when patients have high risk features associated with peripheral arterial disease, and the high risk features being a previous history of myocardial infarction or a stroke, then they're considered high risk and they would benefit from a combination rather than clopidogrel. They would benefit from a rivaroxaban 2.5 milligrams BD, and aspirin 75 milligrams once daily for lifelong. This is a rather new evidence. So NICE guidelines also recommend three-stage approach to patients with intermittent claudication pain. The first line treatment is supervised exercise program. So the idea of this is that they're supervised. It's a group exercise session, much like a cardiac rehab session. They get 2 hours of supervised exercise per week for 3 months, and that is shown to be beneficial in increasing walking distance. Unfortunately, for a lot of the population across Warwickshire, this supervised exercise program is not currently funded or available in the NHS. Across Warwickshire, I think currently there's only City of Coventry healthcare that's in the city center in Coventry that are providing this supervised exercise program. Um, Second line treatment is if patients have no benefit from supervised exercise program and if all the risk factors are controlled, then we consider them for a minimally invasive percutaneous angioplasty treatment, if suitable. As a last resort, if there's no improvement with exercise and walking and they're unsuitable for angioplasty, then we consider them for bypass surgery. But this is a minority of the patients. Now, a lot of the GPs wonder why we don't, when we get a referral for patients with intermittent claudication, it's more likely than not that we would just discharge them without any vascular intervention, and that might be a bit counterintuitive because you feel that as vascular surgeons, we should be intervening more on these patients because they've got blocked arteries or narrowed arteries. Um, but we don't, and the reason being that there is increasing evidence. So I've put two large studies here. The first one is a study in the UK which shows that when patients present with claudication, if you intervene early with a vascular intervention, you increase the risk of major limb amputation compared to not intervening at all. Then there's a second study involving thousands of patients in the US, which showed very similar findings that with revascularization, we increase the risk of subsequent major limb amputation. So vascular intervention in intermittent claudication comes at a cost. We try and improve their quality of life, but a lot of these patients can lose their leg. Um, the risk of losing the leg is higher with intervention compared to conservative therapy. So, looking at some of the common problems that you are likely to encounter in primary care with respect to peripheral arterial disease. So, low ABPIs. I mean, we get referrals from low ABPIs. What does low ABPI mean? It means two things. One is patients may have asymptomatic peripheral arterial disease, or often the ABPI is done by untrained staff with poor technique, and therefore the result is unreliable. I know this may sound a bit rude, but the reason I say that is because when we get patients with low ABPI and we send them for an ABPI in our vascular lab, often it comes back as normal. So, what do we do with this low ABPI? I suggest correlating that clinically with the history and examination. History is, do they have symptoms suggestive of intermittent claudication pain or ischemic rest pain? Examinations, does the foot look pink? Is the capillary return time 2 to 3 seconds? And have they got palpable foot pulses? If they've got no symptoms and clinically the foot looks well perfused, you just have to reassure patients that there is no peripheral arterial disease and the ABPI reading is likely to be false. If, however, if they've got no symptoms but your clinical examination reveals peripheral arterial disease, then you start them on best medical therapy, which is risk factor modification, clopidogrel 75 milligrams once daily, statin therapy for lifelong. They do not require any referral to the vascular service because we are not going to intervene on patients with asymptomatic peripheral arterial disease unless, of course, they have symptoms suggestive of claudication pain or ischemic rest pain. High ABPIs. This is again a very common referral that we get, and most of these patients don't need to be seen in the vascular clinic. What does high ABPIs mean? It means that their arteries are stiff or calcified or incompressible. And high ABPIs are very common in patients with diabetes, especially if they've got long standing diabetes for many years, or they've got chronic kidney disease, or on dialysis. It can indicate the presence of peripheral arterial disease, but often, again, it's because of poor technique. I mean, in fact, in the recent past, I've had more referrals for high ABPIs in a routine screening, and really when sometimes when we recheck the ABPIs, it's absolutely normal. So it is pretty much due to incorrect technique. So again, like low ABPIs, you correlate that with the clinical history and examination. And if they've got no symptoms of peripheral arterial disease and no signs, then they do not require any referral or any further action. The other question that we get routinely asked is compression therapy. You want to give somebody some compression stockings, but they can't have a Doppler test, or they've had a Doppler test that's abnormal. What do we do? So ABPIs are not required if patients require only class 1 and class 2 compression stocking, because they are milder form of compression. Compression is up to 20 millimeters of mercury, which is pretty mild. If they require higher degrees of compression, then yes, I would recommend routine ABPI testing. But how do we know that they're suitable? Again, clinical assessment. If they've got no symptoms of claudication pain or ischemic rest pain, and they've got well perfused foot with palpable foot pulses, you can be pretty confident that they don't need Doppler testing, and they can have class 1 or class 2 compression stocking. If patients require full compression therapy, which is higher um, degrees of compression up to 40 millimeters mercury, then don't rely just on clinical examination, but cross-check that with a ABPI or a TBPI, which is ankle brachial pressure index or toe brachial pressure index. So as a guide, we use uh, ABPI of zero point 0.9 to 1.2 or 1.3 even as suitable for full compression therapies. If they're between zero point 0.7 to zero point 0.9, that indicates some mild peripheral arterial disease, and therefore we recommend reduced compression therapy. If the ABPI is less than zero point 0.6, that indicates presence of severe peripheral arterial disease, and they're not suitable for any form of compression therapy, uh, and a referral to a vascular clinic is recommended. So that's all about peripheral arterial disease. If there's no further questions or anything, we can move on to the next topic, which is varicose veins. Are you all happy with that?
There are no questions in the chat.
Good. Okay, so we'll carry on with varicose veins. So again, varicose veins, very common problem that we see. Um, this is the classification that we use. It's a scientific classification. It's different from the CCG classification that is used for commissioning purposes. So varicose veins can vary in severity. So it could be, these are thread veins, purely cosmetic, doesn't cause any complications or problems, not treated in the NHS for obvious reasons. Now, these are quite significant varicosities. They're called C2 varicosities. They can cause a lot of symptoms, but no complications. And unfortunately, these are also not treated on the NHS currently due to funding and resource constraints. And that's different from what the NICE guidelines recommend. C3 is when they have varicose veins with ankle edema. C4, much more severe. They've got varicose veins, but they've also got skin pigmentation suggestive of lipodermatosclerosis. This is more sign of more advanced venous disease. And when they get to C4, C5, and C6, we tend to prioritize these patients for varicose vein intervention in the NHS currently, mainly because of resource constraints. So C5 is a patient with a healed venous ulcer. C6 is somebody with active venous ulcer. Some facts about varicose veins. So up to 1 in 5 patients with symptomatic varicose veins can progress to a venous leg ulcer over a 6-year period. 1/3 of these patients with uncomplicated varicose veins can develop C4, C5, or C6, which means that they can develop skin changes over a 10-year period. So patients sometimes have a venous scan which shows that they've got a venous reflux, but they don't have any symptoms, and they ask the question sometimes: do we need to be concerned about it? What's my chances of getting developing varicose veins in the future? And that's a 1/3 chance of developing varicose veins over a 4 to 5 year period if you've got asymptomatic venous reflux. Again, there are nice guidelines and which are pretty old now, nearly more than 10 years old. But the most recent guidelines, which are very useful and very comprehensive on varicose veins, is the European Society of Vascular Surgery guidelines. So nice guidelines. This is the guidelines on treating patients with varicose veins. Uh, Now, nice guidelines recommend endothermal ablation as a first line therapy. Endothermal ablation includes basically involves using thermal energy or heat energy to close off or ablate the the vein with faulty valves. It could be laser treatment or it could be radio frequency ablation. These are the two main heat sources that we use. If endothermal ablation is unsuitable, then the second line treatment is ultrasound guided foam sclerotherapy. If that is also unsuitable, then surgery in the form of high tie and stripping, which is very rarely done. I mean, 99% of my practice now is either endothermal ablation or foam sclerotherapy or a combination of the two. So these are some pictures. So this is the first picture of a patient having radio frequency ablation. We put this radio frequency catheter into the great saphenous vein from the knee to the groin. And then we put local anesthetic called tumescent anesthesia. So the whole vein is covered with fluid and local anesthetic. And then the tube that we put into the vein or the catheter heats up inside the vein with radio frequency energy to 120 degrees and will block and kill the vein. We could also use laser. You could put a laser fiber through the vein and do the same. This picture here is the patient having ultrasound guided foam sclerotherapy. So you cannulate the vein with a butterfly needle using ultrasound, and you mix up a liquid, chemical, and air together, and we inject that into the veins to kill these veins off. And the third picture is very uncommon these days, is a great saphenous vein that's been stripped out. These are the patients that I've treated under local anesthetic, clearly had significant varicose veins due to a great saphenous vein reflux. So the great saphenous vein was treated with radiofrequency ablation, and the bronches were treated with avulsions, which is little cuts here to remove the bronches. And they've also had foam sclerotherapy. So the brown mark here is as a result of the foam sclerotherapy. So the general idea is that you use thermal ablation either with laser or radio frequency for the main truncal vein, which is the main trunk that's feeding the bronchus. And for the bronchus, you use either ultrasound guided foam sclerotherapy or surgical removal or avulsions. So that's pretty much the common practice. So phlebitis, we'll talk about some common complications that are seen in patients with varicose veins. They can come with this condition called phlebitis or superficial thrombophlebitis. It's an acute, painful condition. Varicose veins have suddenly become hard, red, and inflamed and painful, and very tender to touch. So that's called acute phlebitis. Essentially, it means that there is inflammation and thrombosis of the superficial veins. Now, it's a condition that increases the risk of DVT. So therefore, it's kind of a medical emergency, not much of a surgical emergency. The medical treatment is basically to reduce the risk of deep vein thrombosis, which obviously involves anticoagulation. Uh, there are different options, but the most common option used these days is a newer oral anticoagulant like apixaban or rivaroxaban for duration of 6 weeks to 3 months, depending on how severe the phlebitis is. Uh, we generally tend to see patients with acute phlebitis as an elective after 3 to 4 months of their phlebitis to consider varicose vein treatment to reduce the risk of future or phlebitis in the future. The acute treatment is anticoagulation with local non-steroidal gels and ice packs to reduce inflammation. So for mild phlebitis, where you've only got localized area of redness and tenderness, usually below the knee, can be treated by topical non-steroidals, topical ice packs, and a shorter duration of anticoagulation for 6 weeks, and a routine vascular referral. For people with moderate to severe phlebitis, where the phlebitis is involving the main great saphenous vein or the short saphenous vein, or closer to the groin or the saphenofemoral junction, these are severe phlebitis. So for these patients, they require a longer course of anticoagulation, up to 3 months. They also require a referral to hematology to rule out DVT or thrombophilia, especially if the phlebitis is very close to the saphenofemoral junction in the groin, and a routine vascular referral to treat their varicose veins. Now, bleeding varicose veins, hopefully uncommon in the GP practice, but possible. The main treatment, acute treatment, is to apply compression therapy to the site of the bleeding and elevate the leg to reduce venous hypertension. Uh, Sometimes these above measures may not control the bleeding. They may require a referral to accident and emergency or vascular service for definitive treatment, but it's unusual. Most of the bleeding can be controlled with compression therapy. When we do see patients with acute bleeding, we tend to perform foam sclerotherapy to these bleeding varicose veins to pull them. Um, venous, I think I've got a few last slides. So venous leg ulcers. So essentially, they're all usually managed in the community ulcer clinic, but the main treatment for them is multi-layered compression bandaging and leg elevation as much as possible. After the venous ulcers heal, we the new evidence we've gone through the ABPI again. So again, compression bandages is a specialized skill. It's usually done by dedicated leg ulcer nurses. There's new evidence that graduated compression stockings. So even when they have an active leg ulcer, if patients can tolerate stockings, You can just put dressings on the leg ulcer and stocking on top of it, and it's as good as a or equivalent in terms of healing to a compression bandage. This is the evidence about from a randomized controlled trial, which shows that in patients with varicose veins and associated venous ulcer, if treating the varicose veins with either thermal ablation or foam sclerotherapy has two benefits. It improves ulcer healing and it reduces the risk of ulcers recurrence. So we tend to see patients with active venous ulcers and look for evidence of superficial venous reflux or duplex. And if they have one, we tend to treat them as a priority to improve ulcer healing. Thank you very much for listening. Very happy to take questions.
Any questions? Are you all sure you don't have any questions? Oh, right. Let me just have a look in the chat.
Okay, I'll log into the chat as well.
Okay, in those patients with varicose veins with symptoms but no skin changes, is there anything they can do to avoid progression?
Unfortunately, no, really. There's no medications. The only thing that they can do to control the symptoms is compression stockings. But if you look at the NICE guidelines, it's very clear to say that the NICE guidelines say do not offer compression stocking because it really doesn't treat varicose veins. It's mainly for comfort. It also doesn't prevent progression of varicose veins. There's a often feeling that patients have that if they wear compression stocking for very long and if they're very compliant with it, that they can reduce the progression of varicose veins. I don't think so. There's no evidence that it does, but it can provide comfort. I hope that
Thank you.
answers the question in some way.
Another question, would you advise referral of patients with mild intermittent claudication or for us to manage risk factors and refer if deteriorating?
That's a great question. And it's such a common condition. Ideally, in an ideal world, we would like to see all these patients and modify the risk factors and enroll them onto a supervised exercise program. But unfortunately, I'm sure you all know NHS is being, we prioritize patients in the NHS very differently, and these patients are a low priority currently. So in the current climate, I would suggest that as soon as possible, you start them on best medical therapy, control the risk factors, and refer only if you feel like their symptoms are getting worse to a point where they're getting lifestyle limiting claudication pains.
Right, I've got a couple more questions here. If a if a patient has a raised ABPI and mild symptoms which don't appear to match, would you recommend a referral for repeat if possible, or just a direct vascular referral?
To be honest, we don't really want to see any patients with high ABPIs unless they have very typical symptoms. Again, only because of resource constraints. In our current capacity, we just cannot provide that service in the NHS. So unless they have typical symptoms of claudication pain or ischemic rest pain, then I don't think we can see these patients in the NHS. I mean, obviously it's different in the private sector. We're very happy to see them, but in the NHS, due to resource constraints, I'm not sure that is practically possible. Although, in an ideal world, we'd like to see them and make sure that they're okay. In a practical sense, it's just not possible in, at least in the current climate.
Next question. For those with superficial venous thrombophlebitis, do these need USS or this clinical?
Yeah, it's a clinical diagnosis. So, you know, the veins they feel hard, they're lumpy, and they're red and inflamed. But, you know, I'm sure it's, in a lot of the hospitals now, the DVT nursing team have taken over management of patients with acute thrombophlebitis, superficial thrombophlebitis. So they often do the ultrasound is mainly to rule out deep vein thrombosis, and also to check whether they've got any main truncal venous phlebitis, if that makes sense. If they've got like a great saphenous vein or a short saphenous vein that's affected, then it means that they're high risk of DVT and they require prolonged anticoagulation. Whereas if the phlebitis is just branch veins and the main veins are okay, they require a very shorter duration. So it is a clinical diagnosis, but ultrasound will add to the management plans.
Thank you. Final question that I've got right now. Any particular brand or make of compression stockings that you would advise patients to buy?
Not really. I mean, I don't endorse any brands. I don't have any stocks or shares in any companies, unfortunately. You know, some of the reputed brands are Medi UK. Sorry, Medi UK and Sigvaris. So often the problem is actually, I feel that signposting patients to a good resource is an issue, because a lot of the GP practices don't have surgical appliances departments. NHS is not able to provide that service currently. So it is difficult. We are in the process of setting up some kind of a private service for this, where we measure their leg, if necessary, do a Doppler and signpost them to a reputed company for compression stocking. But hopefully that answers your question to some degree. Sorry, I know it was a bit vague.
Thank you. That there aren't any further questions. So if anybody has another question, please put your hand up and let us know. Otherwise, thank you very much, Devaraj, for the lecture. We would hugely appreciate it if you wouldn't mind filling in the feedback form, because that does help us shape future lectures, and also will help the consultant as well. Vicky has attached it to the chat, and we can send it out again by email. But if there are no more questions, thank you very much for attending, and have a lovely rest of your evening.
Thank you everyone for attending this
Thank you.
evening. And I'm sorry it's a bit different on Teams compared to face-to-face. It's but I hopefully it was useful. Have a nice evening. Bye.
Thank you. Bye.
Bye. Bye, Mel. Bye, Vicky. See you.
Bye.
Bye, Dev. Thank you very much.
Bye.